guys, this is the Respiratory EENT Pharmacology Review. We are on number, 5, I think, out of the series, and this section is a little bit kind of just like cut and paste, I guess, is be the way I felt about this series. So just reminding us, which meds are on here and how they overlap a little bit. Okay, so if we look at the overview for all of the respiratory meds that we're seeing, we're going to have some for allergy and asthma. We're going to have decongestants. We're going to have mast cell stabilizers, bronchodilators, and then we have the anti-inflammatory therapy with the steroids, the leukotriene blocker, and then we have COPD and airway toning meds. And then we have emergency meds and then topical decongestants, which cross over to the ENT, obviously. Okay, so all of the meds that we're going to see on this section for respiratory include allergies and asthma. Will include first-generation antihistamines, so that we have the diphenhydramine, hydroxyzine, and promethazine. We have the second-generation antihistamines, cetirizine, fexofenadine, and loratadine. We aren't talking about those very much on this section. Mostly we're talking about the rest. Decongestants include phenylephrine, pseudoephedrine, and epinephrine. And then we have the mast cell stabilizer, cromolyn sodium. Bronchodilators include short-acting beta-2 agonists, or the SABAs are albuterol primarily, and the long-acting beta-2 agonist is the long-acting LABAs are salmeterol. So anti-inflammatory therapy includes the steroids, inhaled corticosteroids, including beclomethasone, budesonide, fluticasone, and mometasone. And oral, we can take it orally too, sometimes for calming the system down. The leukotriene blocker is montelukast. We'll talk more about that one. COPD, airway tone, we're looking at muscarinic blockers, so those are anticholinergics. Ipratropium bromide and tiotropium bromide are the two there. And then we have the cough mucus and adjunctive antitussives, so there's a little overlap here sometimes with ENT. Benzonatate, codeine are the two antitussives. Mucolytics are acetylcysteine, or NAC, and guaifenesin. And then the emergency airway drug is epinephrine, of course, and the topical nasal decongestant, and that can be also used here as oxymetazoline. NPLEX notes here. The long-acting beta agonists are not used for rescue, so that might be a question on the NPLEX. Only the rescue one is albuterol. Budesonide is the preferred treatment for pregnancy, for the ICS drug. And oxymetazoline is a 3-day max. So here we've got there's rebound congestion. That might be a question they pull out. And then also that the opioid antitussives are not first line. So probably asking questions about, are you using those first or second? So here are the buckets for the respiratory system. We're going to have rescue bronchodilator. So that's your short-acting beta agonist. That's albuterol. We're going to have controllers of inflammation. So those are your inhaled corticosteroids, ICS. We have long bronchodilators. That's the LABA, salmeterol and formoterol. And they're usually used in conjunction with the corticosteroid. And then we have COPD, bronchodilation, anticholinergics. So those we just talked about, ipratropium, tiotropium. Those are your COPD ones. And then allergic aspirin exasperated support. So leukotriene blocker, the montelukast is there for that one. And then antitussives are benzonatate and codeine. Obviously, codeine's the opiate. And emergency airway is epinephrine. All right, so let's talk about short-acting beta agonists. So albuterol. I'm sure you guys are very familiar with this one by now. ProAir or Ventolin, brand names. Class beta 2 selective agonist. So this is a bronchodilator. It's putting the lungs into fight or flight. Used for acute bronchospasm, especially asthma. It's only a rescue inhaler. The timing of onset is 15 to 30 minutes. So usually the dosing is 2 puffs every 4 to 6 hours, 2 to 3, depending on your person's size. And the black box warning on this, according to Fleetwood, is that if it's used more than 2 times per week, it increases the risk for complications with asthma. So it can actually promote the asthma symptoms. And that kind of makes sense if we're not treating the autonomics here and why they're swinging so hard into fight or flight or the allergy or whatever else it's contributing underneath. So rescue inhaler only, short acting beta agonist. So that's the black box is paradoxical bronchospasm. It also does, a few of these drugs actually are shown to have prolonging the QT effect to them, and this is one of them. So we can cause deterioration of asthma if they overuse this. Inhaled steroids or inhaled corticosteroids. Your main controller here trying to knock down the immune response. So we have fluticasone, which is Flonase, and Flovent oral. We have mometasone, which is Asmanix or Nasonex, nasal. We have beclomethasone, which is Qvar oral or Beclovent nasal. And we have budesonide, which is Pulmicort oral or Rhinocort nasal. So these are the ones that we use. They use for longer term knocking down the immune response. These have anti-inflammatory effects, obviously, because they're corticosteroid. They reduce airway inflammatory cells, and so they suppress the immune response there. They're not curative. They must be used for a longer period of time to be effective. And like I said before, she said they oftentimes are adding these into the other ones to try to knock the LAVAs down, longer term effect ones to be more useful over time. Okay, so here are long-acting beta agonists combo therapy. So they're paired with those ICS inhalers. The examples are fluticasone and salmeterol together make Advair. So if you're looking at Advair, this is that combo therapy. It's got that ICS and the LABA in it. So there is, of course, the exam warning or increased safety warning here. So this is probably looking at something that might be on the test. The long-acting beta agonists increase asthma-related death risk if used inappropriately. So used with ICS when indicated, step down when controlled. So this, let's look into her notes on this a little because she seemed like she went off on this quite a bit. That with asthma, it's a pretty big risk over time. This one also can prolong the QT interval. 12 to 24 hour duration of action though, so this one is dosed less frequently but chronically. And then she told me the research on this was never goes past max of, it seems like about 10 months or something was what she was saying. And but people obviously are being put on these for long periods of time. That may not be your best choice for your patient. Obviously get underneath and fix the core issue. So the black box warning is asthma-related death. Currently available data are inadequate to determine whether concurrent use of inhaled corticosteroids or other long-term asthma control drugs mitigates the increased risk of the death from the LAVAs or not. So if you're taking if you're taking them off their Advair, step it down slowly. This is, you got a combo here that's very strong, knocking down the sympathetic response or activating the sympathetic response and also knocking down immune response simultaneously. So be very careful taking them off of Advair. All right, shifting gear. So we're going to go into COPD and look at the anticholinergics. They are ipratropium and tiotropium, or ipratropium is Atrovent and tiotropium is Spiriva. These are used to make COPD maintenance bronchospasm, so bronchitis and emphysema. They are an M3 receptor agonist. So this one, M3 is for smooth muscle and mucus. Tiotropium antagonist. It blocks the ACH effect at M3. So we have tachycardia. Side effects can be tachycardia, nausea, dry mouth, constipation, and urinary retention. So we're blocking acetylcholine so we don't fill them with mucus at the M3 receptor so that we can get the breath back in there. But look for the side effects with the heart, dry mouth, constipation, anything when we're shutting down all the mucus production, you're going to see all the drying of the system. So any of time you're having the anticholinergics, you can see drying symptoms. Okay, leukotriene blocker. So the montelukast is Singulair. This blocks leukotriene receptor effects LTC4, LTD4, LTE4. She was saying that this is an interesting, it seems to block all of the, let's see how she said it. Maybe I'll make sure I get it right. The muscarinic 3 receptors, the most important in mediating smooth muscle contraction and mucus gland secretion. So it does antagonize the effect of acetylcholine at M3, tiotropium does. So we're shutting off the acetylcholine. We talked about that. The montelukast inhibits the binding of those, produces immediate small improvement in lung function, reduce frequency of exacerbations, and improves asthma control as well. So we're trying to block the leukotriene. So the leukotriene, again, was, if you remember, is knocking down T cell activity. This is used more for exercise-induced bronchoconstriction, allergic rhinitis, and aspirin-exacerbated respiratory disease or aspirin-sensitive asthma. So if they're on Singulair, it has more to do with blocking that secondary effect from it. Okay, let's move a little into cough here before we get into EENT. So we had 2 main cough suppressants that may show up on the NPLEX. On the review she went off for quite a while on dextromethorphan, which is Robitussin, Robitussin DM. So Robitussin's guaifenesin plus the dextromethorphan, the DM part. She said that, so that isn't on the NPLEX, I guess, because it's over the counter. We're not seeing dextromethorphan on this list. So look for, instead of benzonatate and the opiate codeine are the 2 that are probably likely to be listed here. Opiate antitussives are not first line, so that's the first thing to think about. And so you also need to avoid them in respiratory compromise. So both of these guys act on the CNS, so they're blocking the cough response, so they're cough suppressant into the medulla. So you want to think about that being an impact here. Your non-opiate is, so benzonatate is peripheral so the benzonatate works differently. It actually stops the lung stretch receptors at the lung versus the codeine, the opiates, which stop it in the medulla. So the benzonatate is cousin to lidocaine, I believe, or basically an anti pain med. So it's going to anesthetize or stop the response of the lung stretch receptors. And if you have to swallow it whole, there's a laryngospasm risk. So that might be something they ask about. Obviously, it's got to get down into the lungs. And the reaction, though, if it does anesthetize down the trachea, you might have more going on than that. Opiate antitussive is codeine. Obviously, we have to have a DEA to get to offer this one. It suppresses the medullary cough center, and it is an opiate. It's cough suppressant is its limited role here. Your side effects of codeine obviously are sedation, constipation, respiratory depression. So warnings are dependence and misuse potential for the codeine. And again, remembering that's the one that's the CNS impact or medullary cough center. All right, decongestants. So this is where we start to bridge into ear, eye, nose, and throat. Pseudoephedrine is Sudafed is the main one on there. And systemic, we have Sudafed PE or phenylephrine. Our mechanism is adrenergic agonists, so we're putting them in fight or flight, which causes vasoconstriction in the nasal mucosa and decreased congestion. So pseudoephedrine and phenylephrine both impact blood vessel contraction and nasal mucosa. So remembering that when they decongest, they're knocking down mucus cells, and they're knocking down vasoconstriction to the area. The topicals are oxymetazoline, which is Afrin. So this is also used in the eye section, but oxymetazoline in this case is going to be a decongestant, and it can majorly cause a 3-day limit on rebound. So if it's used for more than 3 days, you're going to have rebound congestion. I'm sure many of you have figured this out with your inhalers or the nasal sprays. Okay, so that'll be in the ENT when they're just trying to do UTI, upper respiratory tract congestion. This is used, though, Afrin is used to get the full lung or lower respiratory addressed as well. Okay, so moving into ENT. Here are the NPLEX drugs for this. So we have cyclosporins for the eyes. We have dry eyes. We have cyclosporins. For infection, we have sulfacetamide and gentamicin. And erythromycin was on her review, but I didn't see it on this one. Glaucoma, we're going to use pilocarpine, timolol, and lantoprost. Mydriasis or cycloplegia, we use atropine. So if we need to dilate the eye, we use atropine. Post-op pain and inflammation, we use nepafenac, which is, post-surgery usually. Allergy drops, we've got cromolyn sodium, olipidine, and decongestants, we have oxymetazoline and phenylephrine. And then the intranasal steroids, we have beclomethasone, budesonide again, fluticasone again, and mometasone. So we got crossover on the steroids. And then we have combos. So the antibiotic plus the steroid, we usually use neomycin and polymyxin B plus hydrocortisone. So you might, and of course, as naturopaths, we're using more combos of these with the compounded nasal formulas, but this is the NPLEX version. And then our vestibular motion disorders will come in here, which are the antihistamine meclizine, the anticholinergic scopolamine, and then promethazine. All right, topical decongestants. Starting here, so oxymetazoline and phenylephrine. And we just talked about oxymetazoline a little on the last slide. This is Afrin, and phenylephrine is neosifrin spray or Sudafed PE pill. The big questions you're probably going to see on the NPLEX again for both the respiratory and for the nasal decongestant is the 3-day max for topical use. Oxymetazoline definitely has a rebound issue big time, and that would be the most likely question for them to answer or ask about. And she didn't talk too much about Sudafed PE there, but same contraindications you have on the respiratory. All right, all ophthalmic antibiotics. So if we're into infection, we have sulfaceramides. So that is blef10, and gentamicin is garamicin is the other term. These are bacteriostatic sulfonamides. So when she said they aren't bactericidal, she's saying this is bacterial static, so it just kind of holds the bacteria in there until the immune system, holds them, isolates them, so the immune system can work on it. So these are used for conjunctivitis, and they are an aminoglycoside. As the mechanism. So conjunctivitis, keratinitis, corneal ulcer, blepharitis are the main indications. And in these, so either of these you're going to see kind of in the broad bucket of eye infection. Obviously, sulfa allergy needs to be prevented or avoided here. The gentamicin is the aminoglycoside, and oftentimes the erythromycin she brought up is used for the superficial eye infections and as drops for the kids when the babies are born. They use the erythromycin. They may also be using gentamicin. The erythromycin was before we had categories, was pregnancy category B, and the gentamicin is category C. So I believe it's still erythromycin they use to put in the baby's eyes if the mom has chlamydia or gonorrhea at the birth. Anything else there? So if probably the question they're going to see is the gentamicin is the aminoglycoside. It's pretty strong. So and would be used if there's a sulfa response allergy. All right, cyclosporins are used for hydrating. Basically, this is Restasis. I don't is the brand. So chronic dry eyes or sicca syndrome suppressed by inflammation. So keratoconjunctivitis sicca. So this is when the person has very dry eyes, they're probably going to be put on the cyclosporin ophthalmic, and the side effect is burning. Not great to use in pregnancy, but they probably will use it since it's was category C. I guess they could probably let sometimes use it. Glaucoma. So we have three big kind of mechanisms we use for glaucoma. The pilocarpine is the cholinergic agonist. The lantoprost is a prostaglandin analog, and the timolol is a beta blocker. So completely different approaches here. So the pilocarpine causes meiosis, which increases outflow, and then glaucoma and meiosis induction. So this is a cholinergic agonist. So pilocarpine is actually going to vasoconstrict or cause meiosis, right? Vasoconstrict the eye in the cases of glaucoma, so that that can narrow the light coming in and help that narrow that whole thing down for them. Lantoprost, the prostaglandin, is actually going to increase water, right? So it's going to increase aqueous humor outflow. This is really likely to show up on the NPLEX because it does have the weird side effect of increasing pigmentation in the eye, or pigmentation changes in the eye to the iris, the eyelid, and the eyelash. So you might remember with latanoprost, that you have, they're going to look like they have makeup on all, I guess. Iris, eyelid, and eyelash all can have a pigment change. Timolol is the beta blocker. It lowers intraocular pressure. And so remember, it's a beta blocker, so it's going to be having all of the beta blocker side effects and contraindications. So asthma, COPD, systemic absorption risk with timolol seems to be a possible question for them to be asking. So look at any overlap on this one as a beta blocker, trying to bring the glaucoma down. Okay, mydriasis and cycloplegia and pain, or plegia and pain. so if after surgery, so this is usually they've done the glaucoma surgery or the cataract surgery, and they're coming out with pain. They're using atropine usually, which is the site for cycloplegia and mydriasis. Uh, the side effect, in order to, it's going, atropine's like belladonna, right? It's going to vasodilate. It's going to the iris is going to dilate, and we're going to have photophobia, blurred vision, and increased blood pressure with that because it's it's atropine. So, and then just for pain, they're using the Nepafenac, um, which is called Ilevro, excuse me, and that's an NSAID ophthalmic. So really, they'll probably give them a combo of some sort. So Nepafenac is for the pain and inflammation after the cataract surgery, and the atropine is to dilate the eye if needed. The pearl here, if there's delayed healing, and corneal the cornea can be affected. Delayed healing, corneal effects. So you want to, of course, avoid using contacts when you're using either of these. Probably you're not going to have contacts on right after cataract surgery. Okay, then we also have the allergies section for the eyes and nose. So olopatadine and cromolyn sodium are the two we talk about here. So olopatadine or patanol and patinase, so patanol for the eye, patinase for the nose, are used for ocular itching or allergic conjunctivitis, and olopatadine, so is allergy response in the eye, allergic conjunctivitis. So its side effect can be local burning, stinging, and dry eyes, blurred vision, and it does seem to, for some reason, drip kind of down into the pharynx and cause cold or pharyngitis symptoms as a side effect. So that, I'm guessing, might be one that could go in on the NPLEX. If you're using the olopatadine for the eye drops that you're for allergic conjunctivitis, you're going to see them show up with almost like a cold laryngitis picture. Cromolyn sodium. So she loved this one. She talked about it being very commonly used across almost everyone except the US for, obviously it's a big stabilizer of mast cells. So we're going to be doing a systemic mast cell stabilizing and preventing the histamine release, because that's where the histamine is released. Multi-site naming pearl. So this means the NPLEX is probably going to look at cromolyn sodium on multiple antihistamine areas on the test. So there's the Intol is the inhaler, gastrocrom is for the gut, so same family. So if they have the Intol, it's for the inhaler for the allergy or the nose, and the gastrocrom is for the gut spasms or calming down the histamine reaction in the gut. All right, ears, corticosporin, otic. So swimmer's ear. So they use neomycin and polymyxin B plus hydrocortisone for swimmer's ear. Corticosporin otic. It also used an ophthalmic version for corticosporin is in use. She was very strongly adamant that neomycin has a potential to cause permanent sensory hearing loss, and is toxic. It's a toxin for the ear, otic toxin. So she said, if you're putting neomycin in the ear when it's all inflamed already, that's a higher risk. That didn't make sense to her as a pharmacist. So we might be able to get these drops done differently, so it's not a neomycin ototoxic antibiotic in there with the polymyxin and the hydrocortisone. But obviously, if they're trying to bring inflammation down there, they have to put an antibiotic in because they're putting it into the head. So they're not just going to knock the immune system down with the corticosteroid without putting some sort of antibiotic on board. But the choice of neomycin in her experience didn't make a lot of sense, since the side effect is sensory neural hearing loss. So swimmer's ear, superficial bacteria infections, post-surgical cavities. Respiratory adjuncts. So we have a couple of things we're using for thinning the mucus here. Acetylcholine, obviously, we know this one, and they are using it as a pharmaceutical in the class as a mucolytic. It breaks down the disulfide bonds in the mucus, so it lowers the viscosity of the mucus. It's used for thick respiratory secretions in COPD and CF. And it's also an antidote for acetaminophen toxicity, as we know, for the liver. So if they may be throwing acetylcysteine in there for the lungs or for Tylenol toxin. Guaifenesin is an expectorant. So this is actually Robitussin, but if it has the DM, then it's the dexamethorphan. Its mechanism of action is increased hydration of the respiratory tract. So it does increase mucus clearance and cause a productive cough. She suggested that if you take guaifenesin, it's really important to take it with a bunch of water. Good to know that neither is a bronchodilator. So really these two just are working on at their adjunctive mucolytics according to pharmacology. So they're used to just break the mucus up. Okay, cough and emergency airway. So again, we see the benzonatate here, which is as an antitussive. It's gonna cause anesthetize the stretch receptors in the lungs so that the cough is suppressed. If there's an emergency need here, then we're gonna have epinephrine. Obviously, alpha and beta adrenergic agonists. So if you have acute bronchospasm or anaphylaxis risk, you're going to be using epinephrine. It's a bronchodilator, major bronchodilator, and also major vasoconstriction with the alpha receptors. The big thing on the benzonatate, again, is the capsule must be swallowed whole, not chewed, so that it doesn't anesthetize on the way down and cause laryngospasm. I think we said that before. And then, of course, expect cardiovascular side effects with epinephrine, because it's epinephrine. All right, NSAIDs, respiratory. So the two big non-steroid anti-inflammatory drugs are the cromolyn sodium we see here again, but we're nebulizing it this time. So that's mast cell stabilizer. One more time, prevents histamine mediator releases. It's used in asthma prophylaxis and not effective for acute bronchospasm. So they may be throwing cromolyn sodium, nebulizing cromolyn sodium in there to stabilize the histamine response. Same drug family as nasocrom and opticrom is the cromolyn sodium. So I think she likes it. It has a safe profile, but it's limited in potency. And it's good here because it distinguishes from the corticosteroids for them to be asking questions about it. I would love feedback from you guys because I've been having pretty good effects with this one clinically. And if any of you have any other kind of stories or things on it, longer risk or longer term, I'd love to hear them. All right, vestibular and motion disorders. So we have three here. We have meclizine, scopolamine, and promethazine. And the vestibular meds often share sedating and anticholinergic profile. So you're going to see these again in neuro for anxiolytics and sedatives. Promethazine is a big crossover on the NPLEX, so let's look for sure at that one because it's the strongest sedator. Sedative, and then scopolamine is usually tested by saying that it comes in patch form. So remember, scopolamine is the patch. Meclizine is an antihistamine 1, first class, vertigo, motion sickness here in this system, and the side effect is sedation, anticholinergic, so drying and sedation. Scopolamine also, these are all the class 1 antihistamines. Effects. They aren't direct antihistamines, so except for meclizine, but they do have similar effects, was what I think she said. So motion sickness, scopolamine is the patch. So remember, the patch is scopolamine. It does cause dry mouth, blurred vision, and confusion sometimes. And then promethazine is the antihistamine antiemetic. So that one we talked about in the GI tract. Nausea, allergy, vestibular symptoms are what we're using it for, and it is a strong sedation effect and anticholinergic. So those are the big ones on the test for the ENT. So this was a pretty short section between these two, but we're going to make up for it next week. We're doing neuro and pain and overdose meds, so or drugs that are used for drugs that you can have addiction risk with. So we will cover those next week. And again, we're going to go to the Saturday time because I'm going out of the country. So if you would like to join me on Saturday mornings at 10 a.m. Your time, then I would love to see you there.